level of accuracy. At least that's what we currently think. And therefore, but ECV has the disadvantage that ECV needs a contrast agent. So because you need pre and post contrast T1. So these are very important questions, especially I think think about the future. It would be great if we could do these, if you could run these CMR protocols with less and less contrast agents. So today we have two stars in that field who both published papers on this topic. And we have Mariana Fontana. Ciao, Mariana. It's great. Thank you for coming. And we have also Eric Schelbert. Hi, Eric, who's calling in from the States. So this is a great opportunity now to discuss this, especially where is currently the borderline between non-contrast and contrast-enhanced imaging for mapping some of the diseases. So we only have half an hour as usual. It's a very informal walk through the PDF. Whoever has a question, please just type it into the chat or just unmute yourself and speak up. And now I would like to ask the authors to briefly walk us through their papers on a high level with some personal remarks maybe, so that we have also some discussion on that. And we could start with either. I don't know who wants to go first, but I would almost ask Eric to go first, because this paper is a little bit more critical and a little bit more, okay, it could be this or that, and then Mariana could then chime in with their experience and their paper. Yeah. So Eric, can you unmute yourself, and I'll stop sharing. So if you could share your screen or share the app you're using for the PDF, and then walk us through it.
Sure. And,
hi.
Hi, Matthias. Can everyone hear me? So sorry to be a few minutes late. Yes, yes. I don't have a camera on my computer. I don't know if you can see my desktop.
No,
can everyone see my desktop?
But if, on the bottom of the window, there's a button. Usually sometimes Zoom has two windows, but on one of the windows at least there's a button called Share. It's green, and if you click that, then you can pick the application you're looking at at your PDF with your PDF. And then you can start share that and just walk through it. Exactly. Now we can see it.
Okay. Sorry to be a little clumsy with the software. No,
that's fine. No problem.
All right. Well, thanks for having me, and thanks for everyone for tuning in. So basically, this paper was this research was conducted to look at prognostic associations for the various parameters of quantifying diffuse myocardial fibrosis throughout the myocardium. And just some background about that. Initially, some of the first papers looked at post-contrast T1 only. There's been a lot of interest in native T1 that doesn't use contrast, especially for patients with renal function. And there have been a number of human histologic validation studies. And I think if one looks at the aggregate data, I think the histologic validation shows the best agreement between human collagen volume fraction and the cardiac MR extracellular volume fraction. So that's, when you're validating a new biomarker, histologic validation is certainly an important domain. But then I think risk stratification in identifying vulnerable patients would be another important domain. So this paper was simply to look at outcomes with all these different parameters. And so we basically looked at native T1, and let me just scroll to the, so this is sort of the money shot, if you will, of the paper. So we basically did Cox regression, we did univariable Cox regression and multivariable Cox regression. And whenever you have multivariable Cox regression, typically the associations with the outcomes goes down a little bit when you have, for example, diabetes in the model, because diabetic patients typically have higher fibrosis anyway. So that's always going to lower the prognostic associations. And in this figure, the p-values really come from the chi-square values in the model. So that's why they're demonstrated here in this bar graph. And the outcomes that we looked at basically were median follow-up 5.5 years after their MR scan, all comers. We specifically excluded patients with cardiac amyloidosis, either at the time of MR or subsequently identified in routine clinical care thereafter. And we also excluded hypertrophic cardiomyopathy, in part because one of my colleagues has an interest in that, so we just wanted to kind of partition out those patients, and then also congenital heart disease. And I think there are just a handful of patients with Fabry's disease and iron overload. We excluded those, but for the most part, it's sort of like all comers. And the Kaplan-Meier curves, which are essentially partitioning out continuous variables to different categories. The editors wanted us to use quartiles. I don't like quartiles so much. I think it's easier, you know, when we think about ejection fraction, we think about how far off normal we are, and quartiles don't really capture that information. Anyway, the data looks pretty good for ECV, a pretty good risk stratification. Native T1 doesn't look so bad either, but there's less discrimination with the lower T1 values. And we also looked at synthetic ECV, and then we looked at ECV, which included focal non-ischemic scar, which is kind of controversial. Some people think you should include it. Some people say you shouldn't. My bias is to include it because there's no quantitative validation of focal non-ischemic scar being a robust quantitative measure of myocardial fibrosis. So I would, my feeling is, why would we let an inferior measure bias downwards a better quantitative measure, regardless of which side of the fence one puts oneself. We looked at it both ways. So the main ECV excluded focal LGE. So basically looking at diffuse myocardial fibrosis, we looked at two short axis myocardial slices, base and mid, and we averaged those two to come up with a single variable per patient. And this is looking at the aggregate patients. So what we see here is that ECV without scar, synthetic ECV, which is a way to basically estimate the hematocrit from the pre-contrast blood T1 and relieve oneself of the burden of measuring contemporaneous hematocrit at the time of cardiac MR scanning. And then also ECV, which included non-infarct focal myocardial scarring. All these things had great univariable associations when one compares it to native T1, lambda, the partition coefficient, post-contrast T1, and even non-ischemic scar in a binary fashion. And when those were the salmon-colored bars, I guess. And when you look at the green bars, the prognostic association diminishes because you're kind of distributing the fibrotic associations across many variables, because other variables in the model are also associated. And we essentially adjusted for everything we had in our model. So, and let me just scroll down a little bit further. Sorry to jump around here a little bit. So the chi-squared values are here. These are the hazard ratios. We express these continuous variables in one standard deviation increments. So when you scale, you know, if you're going to report a hazard ratio for blood pressure, you know, the unit is 1 millimeter of mercury, right? It doesn't really, it's not clinically meaningful to compare hazard ratios when the delta is infinitesimally small. So pretty much an ECV of 4% is pretty significant. That's a one standard deviation. So that's what we use for that. 54 milliseconds for native T1, 5.6% for lambda, 48 milliseconds for post-contrast T1. And, you know, essentially the p-values come from the chi-squared values. So it all favors favors extracellular volume fraction. And I think really you get the best risk stratification with progressive dose response relationships here with ECV that you don't see in the other variables. And then when this went from peer review, some of the reviewers asked for different subgroups. So we basically looked at people with ejection fraction less than 50%, greater than 50%, coronary disease, present, absent, late enhancement, present, absent, people with MIs. And essentially, the main concern was, native T1 is really the competitor, if you will, to ECV. And so, without making this table just incredibly massive, we just focused on native T1 versus the two different types of ECVs, synthetic and also the ECV that had contemporaneous hematocrit measured at the time of cardiac MR. And essentially, we see, if you look at the chi-squared values, they're pretty huge. They're essentially at least double, if not greater, for ECV versus native T1 across the board. And so the upshot of all this data is that similar to the aggregate histologic validation data, ECV also stratifies risk better than these other, what I would consider surrogate measures of myocardial fibrosis. And I think the reason for that is it's simply not confounded by anemia. It's not confounded by variance in renal function and things like that, which also may influence all the other post-contrast measures. And as we know, native T1 measures whole myocardium. There was a recent study that just came out that showed that diabetic control can affect native T1 without influencing ECV. I forgot to have that paper pulled up prior to the meeting. But essentially, I think if one measures the interstitium, which is where myocardial fibrosis and, of course, amyloidosis reside, it makes sense to measure the interstitium with the least amount of confounding possible. And I think that measure that we have is ECV, and that's essentially what the paper was about. So hopefully I didn't ramble on too long. I will now yield the floor to my friends and colleagues who are on the call, and I think I'll just leave it there. So.
Thanks a lot, Eric. That was great. So can you just briefly say how many patients did you enroll there, and what did you use for verifying events? I think you used a public or the public registry, right? The death certificate registry.
Yeah, we enrolled 1,700 patients. Sorry to leave out that information. And we basically looked at death and heart failure events, and there were 162 hospitalizations for heart failure after the index cardiac MR scan, 279 deaths. We basically used the Social Security Death Index as well as the medical record. So our cardiac MR center serves a number of hospitals within the system, and they all share so it's kind of like an integrated health system. It's not quite nationalized. So I think we have pretty good data capture for events.
And of course, the values were all basically acquired as part of a clinical scan, and this is an observational study, but you just took the values as acquired by the scan, the clinical scan, and then tracked then what happened to the people, especially with death, right?
Right, and we stratified the Cox regression models for whether they're hospitalized or not, and essentially adjusted for everything we can. And I didn't even talk about net reclassification improvement, but we basically had significant results across the board. So I thought it was a pretty compelling story that basically, in my mind, establishes ECV as the unequivocal risk stratifier of choice.
So basically, segueing now to Mariana, of course, a question to you could be, you say that ECV is better, but the other question one could ask is, when could T1 be good enough? So even though ECV is better, could you imagine that in certain patients, a native T1 that is sky high would be enough for you in a clinical setting, or would you always go for ECV? Because let's not forget, for some countries and some centers, ECV, where the contrast agent is a problem, not only because of potential allergic reaction and all that, and kidney failure, but also sometimes the costs are pretty high when compared to the US, for example. So, could you think about a scenario where a high T1 would be good enough for you, and you would not go for the ECV?
that was a question to me.
Yes. With your experience.
Yeah, I mean, I only look at native T1 essentially when I don't have ECV, and I kind of use it as a screen for hemochromatosis and Fabry's disease. But otherwise, you know, I have major concerns about, you know, if the scanner isn't properly shimmed, if there is anemia. All these things can influence it. I just think it's a really imprecise measure, and so, you know, it may work out in populations, but in my mind, it's inferior. I mean, it's another data point, but given if I have both T1 and ECV, I put all my diagnostic and prognostic money on the ECV variable.
Okay.
I have them both, and you know, and of course, if they're in renal failure, then I think one is stuck. But then, you know, it's probably better than nothing, and it did have some risk stratification. So I think it's okay. But I think you know, comparing the two, there's no more equipoise at this point, at least in my mind.
Oh, okay, thank you. So that is basically a pass to Mariana. So Eric, if you could unshare your screen, and then Mariana, if you could share your screen. So so now we have Mariana Fontana, who is the senior author of a paper also published in JACC Cardiovascular Imaging. Also this year, the paper is called Noncontrast MR for the Diagnosis of Cardiac Amyloidosis. Mariana, take it from here. And thanks for joining again. I think you're on mute, Mariana.
Yes, sorry.
Yeah, yes. No problem.
Thank you again for the invitation. It's a pleasure to be here exactly 1 year after the last time. So I was on the beach last time, this time in London.
Oh, I remember. That was a very cool one, yeah.
Yes, I was in Tuscany on the beach. So this time is not exactly the same. Just 1 second. Okay. So basically, as we all know, amyloidosis is a group of rare diseases, but when we think about cardiac amyloidosis, we think about maybe two types. The one related to the presence of a plasma cell dyscrasia in the bone marrow, AL, and ATTR amyloidosis, that was thought to be a rare disease, but now has been recognized as an increasingly common cause of heart failure with preserved ejection fraction. So legal enhancement has been considered really the gold standard for AL, and one of the ways to diagnose ATTR amyloidosis that now with the TTR bone scintigraphy also is extremely useful. But basically with LEGAD, we get a very, very typical appearance. The problem is that, as you say, a bit of problems have emerged in the sense, how easy it is to give contrast to patients is different in different countries, in different institutions. And for example, whilst in my institution, we're very relaxed about giving contrast, even patients with kidney failure, dialysis, in almost all conditions, we are one of the few exceptions in the UK, and most UK, but also worldwide places wouldn't give contrast, for example, when the GFR is less than 30. So, having a reduced eGFR in amyloidosis actually is extremely common, not only in AL, but also in TTR. And lately, with the evidence of possible brain deposits, the EMA and the FDA have advised on the use of contrast agent only when the information cannot be derived with non-contrast imaging. So we know that with T1 mapping, we get very high values, but all the studies that have been published before were retrospective studies comparing accord with hypertrophic cardiomyopathy and amyloidosis. So we really didn't know what was the use of T1 in clinical practice. So what we did, we analyzed all patients that were scanned here with a suspicion of cardiac amyloidosis, and between 2015 and 17, and all patients had a clinical evaluation, SAP scintigraphy, echocardiography, assessment of a plasma cell dyscrasia, CMR, bone scintigraphy, biochemistry, and histology. And basically, as gold standard, we use for presence of cardiac involvement, we use the carrying criteria. So, for example, characteristic CMR with LEGAD, with a non-cardiac biopsy, or for AL or for TTR, DPD grade 2 or 3, in the absence of plasma cell dyscrasia, or if there is a plasma cell dyscrasia, a carrier biopsy. So the gold standard for the diagnosis was extremely robust. And in our cohort, because basically we scanned all patients where there was a suspicion, a clinical suspicion of cardiac amyloidosis, out of 868 patients, 50% had confirmed cardiac amyloidosis, 441. 216 had no cardiac amyloidosis, but systemic amyloidosis, for example, renal AL or ATTR neuropathy or other type of amyloidosis. And 211 had no amyloidosis like hypertrophic cardiomyopathy, hypertensive disease, Anderson-Fabry, and other type of cardiomyopathies. So there was a prevalence of 50%, and this is roughly the prevalence that you see in all published papers in tertiary referral centers. So statistically wise, we use a training and validation samples, but this is equivalent, for example, to the bootstrapping approach. So it's just a way to create cutoff and then test the cutoff in a different population. And basically, training and validation cohorts were randomly selected, and they were comparable. And this is basically the diagnostic accuracy on ATT1. So diagnostic accuracy was very high, with an area under curve of around 0.86, with the optimal cutoff being 1,091. But what we thought that actually in this population, we do not want to use the optimal cutoff. What we want to use a cutoff with very high sensitivity to basically exclude cardiac amyloidosis and high specificity to confirm cardiac amyloidosis. Like using, for example, the T1, similar to what we use, for example, BNP in accident emergency. So the patient comes with, I don't know, dyspnea, and then the PNP is normal, so there's a high negative predictive value. So the cutoff with high sensitivity, we would use it to exclude cardiac amyloidosis. So if the patient had an ATT1 less than 1,036, there's more than 99% chance it's not amyloidosis. And at the other end of the spectrum, more than 1,164, the chance of this being amyloidosis is more than 99%. These are all kind of the relative cutoffs. So then we analyzed if this was affected by degree of kidney function or kidney failure, because again, kidney failure is extremely common, and there were no differences. And also if there was differences in patients with nephrotic range proteinuria and non-nephrotic range proteinuria, that again is extremely common, and again, it wasn't affected. T1 didn't show a significant clinical correlation with the GFR, albumin, or proteinuria, again confirming that it wasn't hugely affected by that. And so again, how do we use these values? So when we have a patient with suspected cardiac amyloidosis, then we proceed with a Noncontrast CMR. If the ATT1 is less than 1,036, then the patient has got very high probability of not having cardiac amyloidosis. So what we practically do is we look at the history, and if this together with the history, everything fits and we don't suspect anything, we just stop the scan here. If the patient has an ATT1 more than 1,164, and again, there's a clinical history that is in keeping with everything, and this value kind of from a clinical point of view is not a big surprise, then we could consider stopping the scan here. What we take into account when we use these values in clinical practice is also other factors: kidney failure, patient, how does it tolerate the scan, would it like to have contrast or would it prefer not to have contrast, but then for all the patients with intermediate values, we always consider giving contrast. So how do we use this value in clinical practice? Do we really stop with non-contrast scans in all patients? No, we don't. So what we do, we take these values into the clinical context, and if we think that basically these added with the pretest probability, there's very high chance or low chance of having amyloidosis, we can consider stopping the scan there. So we think that ATT1 could help to make the diagnosis of amyloidosis non-invasively. And specifically in some kind of groups, in some populations group, and definitely where there's a significant kidney dysfunction, we could consider stopping a known free contrast when there is a known NATT1 values. And so we propose a diagnostic algorithm that is applicable to a large proportion of patients, because using this algorithm, roughly 40% of the patients could be kind of diagnosed in this way. But all intermediate value, we should consider giving contrast. When we then compared the T1 with the other parameters, I mean, ECV, as expected, the diagnostic accuracy was significantly higher. This was a request from the reviewers that initially I couldn't quite understand, but to be honest, now I really understand the point, because whilst to me, to some extent, often I don't need ECV to confirm diagnosis. In other centers where the leg gap may be not perfectly clear, having an ECV that gives almost a yes or no answer actually could be extremely useful. So it's not a redundant information. What I actually, when I was responding to the reviewers, I will almost consider a redundant information. Actually, it's not, because it's a way to make the leg gap assessment less objective, give it a number and say, if it's above this, the chance of having amyloid is extremely high. And then, as you can see, actually T2 doesn't have very good diagnostic accuracy, but that is not surprising, because T2 that we think is more related to edema is very variable in patients with amyloidosis and depends on at what point of the treatment they are and what is the disease course and everything. So basically, we propose this algorithm that could be used. I agree. Maybe centers that are more confident giving contrast wouldn't use it in all patients, but in centers where contrast would definitely not be given in certain populations, this is actually a very useful algorithm that I think in the future will be more and more used once the people become more confident with the technique.
Thank you very much. One question is, and if you could also unshare your screen. So one question from me is, in a lot of papers we're typically writing or reading, the diagnostic accuracy is taken for the method as such, but in real life, of course, this is just one piece of the puzzle. So you have the clinical background, you have the history, you have maybe seen the patient and all that. So Eric, in your paper, you had also these cases, ejection fraction above and less, so that includes some clinical parameters. But Mariana, in yours, did you also include, let's say, assess the diagnostic accuracy, or let's say things like the likelihood ratio, so that take into account the pretest probability? And then, because in some patients, I could imagine if you have, let's say, someone with multiple myeloma and you already suspect sort of amyloid being in the mix, and then you do that, and even though you use a test that is not that accurate, but it gives you enough diagnostic information. So what happens if we take into the discussion, and we're already at the top of the hour, but let's give us another 3 minutes or so. If you add this clinical information, and maybe from both of you, what do you think of that? Maybe Mariana, you first.
That's actually a very good question. So what we tried to do initially was to combine the NATT1 with other information from the MRI scanner. So for example, adding LV mass or all the other parameters. But the problem was that didn't add any independent predictive information, because that was the idea as well. You add the wall thickness, the LV mass and everything, instead it didn't. But we didn't do what you suggested. Actually, is very clever suggestion, and we should have probably thought about that, adding a pre-test probability based on the clinical information. Because as you say, if the patient, for example, has got systemic amyloidosis, like renal amyloidosis, the pre-test probability is higher. So, and you are right, this is actually how I use it in clinical practice, because it's me or other consultant assigned to stop the scan. And what we do, we read the letter and we kind of combine this pre-test probability when we decide to stop the scanner. So these, we didn't think about doing that in the paper. We did only with the kind of objective variables like CMR or X variables, but this is actually what we do in clinical practice. And I think is a very good
Yeah. I mean, I see that there are only few papers that do that, and to me, that's a little bit of a let's say a gap between what we do in clinical scenarios and what we do with the method. We are sometimes a bit too hard on us, because no method is perfect, but but even an imperfect method sometimes just is enough to tip me over. So Eric, also having seen that or discussed that now, that paper from Mariana, what is your take on, let's say, native T1 in a patient, let's say, with a fairly high pretest probability?
I like Mariana's approach a lot, because it sort of deals with the fact that there is a spectrum of disease, and I think it works. And so essentially, you know, if one is, you know, the farther the T1 goes down relative to your, you know, scanner's normal values, the less likely, you know, there will be a presence of cardiac involvement from amyloidosis. And I think that's, I like the idea of sort of, you know, giving sensitivities and specificities for the different ranges of native T1. I think it's a useful approach. I like it. And I think, I just wasn't sure, you know, I imagine that one has to kind of establish normal ranges. I just want, so my question to Mariana is, you know, how will this change, you know, say if you're on a different vendor scanner, or your T1 sampling curve is different, you know, et cetera, like, you know, the transferability, like, you know, the usual stuff about, you know, well, we measure T1 this way and you do it that way, and that kind of thing.
Yeah, so to be honest, the input that we got from reviewers on this paper was great, in the sense they improved the paper massively. And one of the suggestions, sometimes it happens, especially in this paper it happened, and they suggested to put a Z-score, so that these could be kind of translated in other centers. So you get your normal values, and then you calculate how many standard deviation it deviates from your normal. And so you can get your internal values that can be applied to your.
Got it.
So that's actually was a suggestion from the reviewer. Very useful, I think.
Right.
Okay, thank you. Yeah, thank you so much. I wish we could, we would have the time to continue the discussion, but I already learned and I enjoyed that very much. So thank you very, very much, both Mariana and Eric. So we're already at the top of the hour. We will also announce that through a tweet. We're now going to a summer break, so the next Journal Club will be on September 3rd. And we will then have a session on perfusion, and we will discuss, of course, the MR Inform trial that has to be discussed. So on September 3rd, we'll be back with the MR Inform trial, one of the landmark trials on CMR first pass perfusion, and we'll hopefully have one other paper that hopefully will be published in the meantime, also discussed on CMR first pass perfusion. So with that said, again, thank you very much for the participation, and I wish you all a beautiful summer. So at least this time, Mariana, you did not have to do that from the beach. I wish you a very good day or evening wherever you are, and I hope to see you sometimes soon here. Thanks again. Bye-bye.
Bye-bye.
Great. Thank you so much.